Hello, happy Friday. Welcome to a virtual morning report. We're super excited for another Friday. Reza is on service. It's his last day and he may or may not be able to make it. We will see. I will channel his magic if he doesn't show up, and we'll bask in it if he does. Yesterday was a very special day for many reasons. One, we had a case from Ravi, and if you haven't heard it, you should totally check it out. We were actually just talking about it behind the scenes. And well, it'll be a tall order to meet a case of that intellectual might yesterday, but we'll try. So I'll open it up in the next minute for anybody who has a case that they want to present today. And Deborah is raising both her hands, presumably not to volunteer. All right, Antonio. Okay, all right. You want to unmute and reintroduce yourself to the VMR community?
Yeah, hello everyone. How are you? I see Katerina is cheering me on. My name is Antonio. I'm a Portuguese internal medicine resident, and I'm currently doing my infectious disease rotation in Katerina's hospital. And I think I was pushed by her to present a couple of cases that I had in store and that I've been wanting to present for some time now, and I hope that you enjoy them.
Oh, absolutely. There's no doubt about that. Last time that you had your active participation has probably been over a year, so it's a delight to have you back.
It was, I think it was, October 2020.
What have you been up to?
How do you remember that?
Yeah.
If you listen to that episode, you'll never forget it. That's why.
Yeah, but I've been following you, of course, every time, and I really enjoy listening to you. I've never stopped following you around, but sometimes it's difficult for me to be present for these VMRs.
Yeah, absolutely. Well, it's a delight to have you back. I also see my dear friend Nalayan with his video on. Oh, it's so great to see you. Hi,
Ravi.
What are you eating?
It's milk and cornflakes.
Oh my gosh! Oh, that's right. It is breakfast for dinner in India, unless you've traveled.
Oh, it's actually dinner time.
Amazing! I absolutely love it. Breakfast for dinner. Nothing better than that. All right, Antonio. I hope you're presenting a foodborne infectious disease to soothe our appetite. If not, I'm sure it'll be equally fun. We're ready whenever you are.
Sorry, I was muted. At some point, I'm not sure that I can share my screen at some point because I'll have some pictures to show. But yes, yeah, I'll start presenting then. So it's a young woman, 20-something young woman, presenting, and she was actually triaged to the emergency room with a complaint of right-sided weakness, so right-sided hemiparesis. And I'll give you just the first aliquot with presenting the history of presenting illness. So basically, what she told us was that it all started 2 days before, and she noticed when she was sleeping, when she was turning in bed, she noticed that the right side of her body was not moving very well. Basically, her right forearm. And associated, she mentioned that she had some paresthesia on her forearm, but mainly on her right hand. On the next day, she said that her weakness was actually better. What she was really noting was pain on her elbow, pain on her knee, and pain on her hand, and that was making it difficult for her to pick up weight. She worked around kids, and she was having difficulty picking them up because of the pain. On the next day, she noticed a few spots on her skin that were appearing, And because all the other complaints persisted, the pain and some difficulty with her strength, she presented to the emergency room. She denied fever, headache, any photophobia, no weight loss, diaphoresis, and any other neurological complaints. And she didn't have any particularly relevant exposure. And that ends the first aliquot.
I absolutely love this aliquot because I think that we're standing in very shaky ground. And the reason that is that the two dimensions of this case, the apparently neurological one and the apparently cutaneous one, are not quite clarified. It's almost like having to talk in a language without knowing the alphabet. And we really have to clarify the alphabet before we can put it into words. And so here, the neurological dimension is one in which we aren't definitively localized into the neurological system yet. So let me explain what I mean by that. The patient is describing some sort of movement issue and some sort of sensory issue. But the movement issue could easily be orthopedic in nature, like a tenosynovitis, and the sensory issues could easily be reflective of a metabolic abnormality like hypokalemia. And the similar thing about the cutaneous findings, they're described as spots. But the spots, are so loose in their description that it's hard to make any definitive progress. And so this is a case that highlights the power of physical exam that will radically change the assessment of this condition. And I think what I'd be paying particular attention to on exam is the distribution of the rash and whether there is involvement of the face that may not be appreciated by the patient. Because there seems to be involvement on the right side. She's confident about that. She's confident that her arms are involved and her leg is involved, but the question is the face involved. So in real life, I would be listening to the story and I would jump to the exam. And the key things I would be looking for is a good description of the rash, as well as an understanding, am I dealing with a neurologic or an orthopedic problem? And if it is a neurological problem, to immediately figure out, I know it's right-sided, I know it's arm and leg, and is the face involved? So I'll pass the mic back to you for more information.
Okay, so great discussion, and I think it's nice to keep it a bit vague when we're not sure what exactly is the problem. So past medical histories. She only had mild intermittent asthma, basically. But she took no medication for that or for any other medical problem. She didn't have any allergies that she knew of. No previous history of surgery, family history also non-revealing. She was sexually active with one regular partner with no protection. She didn't smoke, she didn't drink or use any drugs. And she worked, as I mentioned before, with children, around children in an urban area. And she didn't have any animals or recent travel. I'll give you the physical exam. The first thing that stood out was that she was really well appearing. She didn't look sick if she didn't complain of anything. She had a really good general condition. Her vital signs were normal, no fever, normal blood pressure, normal heart rate and respiratory rate. Head and neck exam normal, also cardiopulmonary exam also unrevealing, and abdomen without organomegaly, without pain, anything. Positive aspects. She had pain on the elbow, knee, and the wrist to palpation without edema, without significant edema. So just pain to palpation on those areas. And she did have lack of strength on her right side of the body, mostly distal, so below the elbow and below the knee, and also in the right hand. But the problem seemed to be basically the pain and some difficulty moving the parts of the body because of the pain. Her reflexes were normal. So the deep tendon reflexes were normal. There were no facial paresis, any cranial nerve problems. She did have some, she complained of paresthesia, and she did have some hyposthesia on the first 3 fingers of her right hand. So the thumb and the first, so the three first fingers of the right hand, she did have really consistent hyposthesia. As to the skin findings and no other neurological changes. As to the skin findings, if I can share my screen now.
Go for it. You should be able to.
Okay. So this was what we could see, basically. She had, this is the spot that had appeared on the
I'm not sure. I'm not
Sorry?
sure. I'm not sure it's shared yet. At least on my screen, I still.
Sorry. Okay. Can you see it? Oh, perfect.
It's starting. Yep. Yeah, there we go. Perfect.
Here, this is the spot that she mentioned that had appeared on the first day. So it was basically like really erythematous, a macule on her wrist that was extremely tender to touch and palpation. And then on her left forearm, we could see a small pustule. And she also had a pustule, but I don't have the picture, on her chin. So here. And that's it for the physical exam. And the second eloquent.
Amazing. Okay, y'all. So and I think okay. I'm gonna be real with you all. Being real with you all is actually being more and more transparent about the show of clinical reasoning and the real life thinking. So often, you know, if you've heard of clinical reasoning conversations, people say that clinical reasoning happens in one of two ways, called S1 or S2 thinking. And S1 thinking is meant to say that you tell me the data and I immediately recognize what is going on. And without any explanation, you tell me that there's a young person with dysuria and has pyuria, and I tell you that they have UTI. And there's S2 thinking, which is supposed to be much more systematic, and you like go through things in a much more logical way. I no longer believe that that's true. I think that everything is really a mix of both. It's just a question of how quickly do you come to your conclusion. If you come to your conclusion in an instant, you call it an S1 thinking. And if you come to your conclusion slowly, you'll think it's S2 thinking. And here I would say that this case immediately generates a working diagnosis. And that working diagnosis should be disseminated gonococcal infection. And then you should step back, articulate your thinking for why you did that. And in the process of articulating your thinking, stop yourself from committing a bias by locking into that initial hypothesis and generate a differential diagnosis for the key features of this case. So let me first tell you why the S1 thinking for this case, in my opinion, is disseminated gonococcal infection. And that's because, quite simply, you have a young sexually active patient who has presumably an arthritis and a dermatitis. That is one of two defined syndromes of disseminated gonococcal infection. The other being a pure arthritis syndrome, usually in the knee. There are other ways that gonorrhea can disseminate, including locally causing a tubo-ovarian abscess and kind of fascinatingly to the liver causing Fitzhugh-Curtis syndrome. So that's the S1 thinking in this case. And now if you locked into that, you'd be making a mistake. Let's go back and try to define this problem. The problem, that the initial thread that we have was neuro versus ortho, and I think the examination supports more an orthopedic cause. The edema and the tightness that's centered around joints supports an orthopedic cause, but the tension with that conclusion is the fact that the patient has overt neurological compromise. She has hypoesthesia in the first 3 digits of her hand. So do you then layer on this neurological consequence to something else, or do you simply say, hey, this person has features of wrist inflammation and has sensory changes in a distribution compatible with median nerve disease, so am I just going to assume that the disease in the wrist is compressing on the median nerve? And that's a good operating hypothesis unless you have more data that suggests otherwise. So I would lump in the sensory complaints and keep that as a working hypothesis that it's all the wrist, knowing that I haven't proven that yet. And so we then come to, well, we have a wrist, we have a multiple joint problem and a rash. How do we approach multiple joint issues? That translates into an oligoarthritis. And an oligoarthritis is an infectious oligoarthritis until proven otherwise, with the main two other differential diagnoses being crystalline disease, which is highly unusual in a young patient, or autoimmune oligoarthritis, which usually maps onto the seronegative spondyloarthropathies that present as an oligoarthritis. The most pertinent seronegative oligoarthritis in somebody with infection in consideration is reactive arthritis, and with the sexual history being pertinent here, chlamydia as another way that you might explain this. So I think we're in the world of presumed oligoarthritis, and that's where infections come to play. And the most important infection to entertain in the world of oligoarthritis is endocarditis. The other one is disseminated gonococcal infection, and here that's where the rash is the tiebreaker. The rash of a pustular rash is evocative of a small subset of infections. The most common cause of a pustular rash in all comers that's infectious in nature is impetigo from Staph aureus. That's by far and away, you'll see impetiginous changes with pustules. But there's a small differential diagnosis for disseminated pustules. And here, the reason they're disseminated is we see them in two anatomical spaces, in the forearm and in the shin. And there, the differential is pretty interesting. It's DGI, disseminated gonococcal infection. It's syphilis, as Carolyn brought up in the chat to think about in this patient as well. It is a very rare but VMR described infection called rat bite fever that Reza and Jack discussed a long time ago in patients who have pet rats. They get bitten and they get an arthritis and a dermatitis. And then there's another infection that's called rickettsiopox. It's aptly named because the rash is very pox-like, and it is a mite-borne infection that actually was brought to national attention here in the United States when there was an outbreak in New York City. So what do you do in real life? I think in real life, you worry about this being an infectious arthritis first, and you try to go after the most tappable joint. But here's a general principle. If you're worried about infectious arthritis, while you're preparing to tap the joint, remember to get data from two other sources. Those two other sources are blood cultures. In septic arthritis NOS, about a third of patients will have positive blood cultures. And the other site is mucosal surfaces looking for gonorrhea or chlamydia. So in this patient, I think blood cultures are wise, as well as getting mucosal swabs of any areas involved in sexual activity, mouth, vagina, and rectum. And with that, I'll pass the mic back to you, Antonio.
Okay, great discussion, as usual. I'll give you what will be the last aliquots before I'll give you the final diagnosis. So in terms of general labs, her hemogram was just relevant for leukocytosis, 14,000 leukocytes with 77% neutrophils. Hemoglobin platelets were normal. Kidney function, liver enzymes, all normal. She had a CRP of 127 milligrams per liter. She took blood and urine cultures that were negative. She had a urinary exam that had 103 leukocytes without blood or protein. And she had a negative HIV test. And that ends the final aliquot, and the next one will reveal the diagnosis.
This is super, super helpful. I think I think I neglected to mention the possibility of HIV. And I think anytime that you're thinking sexually transmitted infections, you want to know that as the potential explanation and as a potential confounder of the immune status of the patient. And essentially, to summarize, Antonio, we have a neutrophilic leukocytosis, but no evidence of disease involving the liver, the kidney, but evidence of marked hyperinflammation with the CRP. And I think that the blood cultures being negative in this instance are helpful. In all comers, you'd expect a third of patients with septic arthritis to have positive blood cultures, but the yield of blood cultures in disseminated gonococcal infections is much lower. In fact, the yield of anything short of the mucosal swab is low. So the yield of the septic fluid, of the actual joint fluid, is pretty low. I think it's no more than a third, and the yield of blood cultures is low. You said something about the UA that caught my eye, and I think that's probably the most helpful lead, which is that you told us that the patient has pyuria without any urine culture growth. And that's a very luxurious information to have in this case. We often don't have those two data points to analyze at the same time because the urine culture comes back 2 or 3 days after the urinalysis. But what pyuria in the absence of cultures tells you is there is inflammation without evidence of a routine infection. And that usually is the result of non-infectious inflammation, such as that occurs commonly in older adults for no clear reason. So a lot of older adults have sterile pyuria and we don't know why. It also occurs a lot in the population that I take care of who have Foley catheters. But it's also a reminder of organisms that don't grow on culture. And the sexually transmitted infections like gonorrhea and chlamydia are great examples, though worldwide, tuberculosis is probably the most common cause. How can a routine infection, say by E. coli, cause sterile pyuria? That's because the infection can be adjacent to the bladder. So appendicitis, pelvic inflammatory disease by garden variety organisms can cause sterile pyuria by irritating the bladder externally, such as from appendix. I'll repeat that. So I think here the presence of sterile pyuria gives a little bit more credence to the presence of some sort of infection, especially with the white cells in the CRP. And it's probably an infection you can't see. And when you marry that with the clinical picture, I'd probably be most worried about gonorrhea and a little bit less about chlamydia as a cause of reactive arthritis. But let's be practical. Say this is the patient in the emergency room. What have we made progress so far? I think we made a lot of progress telling her that the chances of her having a stroke are fairly low, which is amazing and probably very reassuring for her to hear. And you're in a situation where you probably can safely discharge her if you're not worried about septic arthritis, and you're faced with the question of, do you empirically treat her or not? And by the way, discharge her is a function of how concerned you are about her joints. I'll just say that's a in the moment decision about how painful and inflammatory they are. But I would make the argument that empiric treatment for gonorrhea and chlamydia is something that you should consider pending the results. And just so you know, the guidelines have changed to higher dose ceftriaxone for gonorrhea and more encouragement of doxycycline over azithromycin for chlamydia, given resistance profiles, but this is something we should constantly look up. So that would be where I'm at now. And I think the next key step is, what's the gonorrhea and chlamydia swab in all the mucosal sites? And if they are negative, we're in for a ride. If they're positive, this is a great reminder of not an uncommon presentation of a disease with increasing prevalence worldwide. All right, Antonio, back to you.
Okay, thank you. So before revealing the final diagnosis, I would like to just discuss a bit why I think this case was so interesting. I was in my first year of internal medicine residency, starting my internship, so really excited. And in my college here in Lisbon, every year we do an international conference for medical students. And since a couple of years from now, we've had some really interesting guests. And one of the guests is Dr. Lisa Sanders. She's been coming like every year, really nice. And she always presents a case, one of her cases. And I remember in one of her presentations, she mentioned what she thought was the recipe for arriving to diagnosis, or something that she had heard from one of her mentors. And she mentioned three things: that she needed experience, knowledge, and cognitive engagement with the case. And of course, it all probably resumes to experience and knowledge in one way or another. But one of the things that we learned from this case was that, and that is related, of course, to experience and knowledge, is calling things that the patients tell us or that they show us by the right name. And so one of the thing that really reframed the case for us was when we stopped thinking that the spot on her right forearm was skin involvement, and we just thought that it was tenosynovitis, and that was redness from the tendon and not redness from the skin. Because initially we were thinking, okay, this has articular involvement, it has skin involvement, it has neurological involvement, as you mentioned, in the median nerve distribution. So is it vasculitis? Could it be endocarditis as well with the arthritis and the pustular rash? So what really reframed for us was just, wait a minute, if this is not skin involvement on the right forearm, and it's just tenosynovitis, and we have arthralgia, tenosynovitis, and dermatitis because of the pustules on the other forearm and the chin. And of course, then we had the idea of your final diagnosis, which was to test for gonorrhea infection. And so that's what we did. We did swabs of the pharynx, cervical swab, and also urine tests, and they all came back positive for gonorrhea and chlamydia. I think, I'm not sure, but the clinical syndrome was compatible with disseminated gonococcal infection. And so we discharged her from the emergency room, actually. So what we arranged was she looked really well, and we had no idea what was happening at the time. And so we just said, come meet us tomorrow to our ward, and we'll review the case with some more time. And so that's what we did. We didn't admit the patient. And so we just took the swabs. We gave her 7 days of ceftriaxone, and all her complaints were completely over. And then she was perfectly fine after that. And 1 year later, she was pregnant. She had a pregnancy without any problem. So everything ended well. And so this was really interesting case because of the presentation. You've made most of the discussion around disseminated gonococcal infection. Of course, 2 presentations, this tenosynovitis, arthritis or arthralgia, and dermatitis, and the other purulent arthritis. And the diagnosis is basically, or the most, the gold standard, I would say, would be the swabs that you mentioned. Of course, blood cultures and even sometimes cultures of the pustule could yield the diagnosis, of course. But the swabs of cervix, urethra, rectum, pharynx, whatever, those should give you the diagnosis. And so this was really a very interesting case for us because of this idea. And the other part of what Dr. Sanders mentioned, the cognitive engagement, that for you, it was the pustules in the arm and the chin and the sterile period, of course. So I think it was a really good case around clinical problem solving and this small recipe that Dr. Sanders gave us to solve clinical problems. So thank you for letting me discuss, and great discussion as always.
Thank you so much, Antonio. I think that is the way you dissected the elements that are used in this case are amazing. And, you know, for me, you can watch how 2 different people came to different parts prioritizing it. I learned from you, and I didn't make that leap to go from rash to tenosynovitis, even though I, as somebody who works in the ER, see tenosynovitis all the time, usually from excessive use, but also from gout. But now in retrospect, it is much more obvious that was probably tenosynovitis causing the orthopedic sensation of weakness. Yeah, and I love all the points you emphasized. And I would say that you know, there's two kind of background questions since we have time, which is why do some patients get disseminated gonococcal infections and others don't? There's no overt reason sometimes, but the 2 things that you should always study in the background. The one is there's some association with the timing of menstruation, and around the time of menstruation, the infection, if acquired, then is more likely to disseminate. But in patients who have an interesting history, it may represent a complement deficiency and a clue that they may have lupus. So the rate of disseminated gonococcal infections in patients with lupus is much higher than other patients. But those are only account for a small fraction of people who get disseminated infection. The other is the other I think is way more important and a testament to the people examining this patient, which is, how many times have you overlooked a pustule? Pustules are so common and often unrelated that here, that finding of less than 1 centimeter on the skin radically changes the case. And think about that. You're seeing literally a deformity in the skin that is by definition less than a centimeter. And you're saying that has tremendous diagnostic weight here. So kudos to you for or whoever for picking up that very subtle finding, and I think it's amazing how much it changes the case. And lastly, I'll say that the disseminated gonococcal infection is very, very is tricky because the stereotypical arthritis, dermatitis, tenosynovitis syndrome, and the purulent monoarthritis syndromes can be a little bit of a spectrum. There's no reason that the patient has to obviate from one or the other. And the way I remember them is the monoarthritis syndrome, which is purulent, is just the whole weight of gonorrhea in one joint, and the arthritis, dermatitis, tenosynovitis syndrome is more diffuse, and it goes to the tendon, a little bit of the joint, and the skin. And it makes it much harder to actually find the organism anywhere else in this syndrome, but in monoarthritis, you tend to find it more easily. But kudos to you for such an amazing, highly educational case that I think many of us are likely to see with the rising incidence of gonorrhea. And I had a lot of fun going through it. Thank you.
Thank you.
Can't wait for your other one.
Just to say, because I didn't mention it, as what you said in your discussion was what we concluded regarding the lack of sensation in her fingers, and we actually found case reports of pyogenic tenosynovitis with carpic tunnel syndrome or something like that. So it was like contiguous nephritis of the median nerve, just like you were mentioning. So that's what we took. And that's also part of the cognitive engagement. When what you mentioned as separating signal from noise, and maybe I'll put this aside, this hyposthesia, and focus on the wrist, because this is where the problem is.
Yeah.
So
No,
yeah,
I didn't realize
what we put together as well.
That's really cool. I'm glad that a case report out there corroborates that. That's awesome. Well, we're super excited today because our dear friend Sammy is doing teaching points for the very first time. He was on the fence, but it looks like he took that leap of faith with just a touch of peer pressure from Katerina, Deborah, and many others. All right, Sammy, the mic is yours.
Okay, let's go for the teaching points. So this is a really interesting case. Thank you so much, Antonio, and great discussion. And also the chat was awesome. I learned a lot. So here are the teaching points. When approaching a vague neurologic complaint, consider musculoskeletal, for example, pain due to tenosynovitis, and metabolic disorders, for example, hypokalemia. And it is also important to check for asthenia versus a true neurologic deficit. A clue would be that the patient also has muscle weakness or fatigue also at rest. This would point more towards asthenia. Then we also talked about the different patterns of clinical reasoning. There's the type 1 thinking or S1 thinking, and the S2 thinking, the type 2 thinking, and the S1 is more fast, like Rabi when he saw this young woman with this dermatologic complaints and the possible arthritis. So he immediately thought about an STD that could maybe be causing all of this. But it's also important to step back and think, what else could it be? Go through a more systematic approach, and that it's also where our schemas are so important to stay broad and not throw our anchor early on a certain diagnosis, which is sometimes the diagnosis, but it's important to stay broad. And yeah, most clinical reasoning is a mix of both, as we saw in this case. When we see arthritis and the dermatitis in a young individual, we should always think about disseminated gonococcal infection, but also infectious endocarditis, red bite fever, endemic fungi. A lot of pathogens can cause that. what I also found interesting is the neurologic complaint in musculoskeletal disease. I remember a case discussion where the patient had neurologic disease due to the muscle swelling due to the poor myositis. And so this can also be causing, for example, by a musculoskeletal disease, for example, carpal tunnel in the setting of tenosynovitis. When we approach oligoarthritis, we should think infectious first, but also crystalline induced autoimmune. And when thinking about the autoimmune causes of oligoarthritis, always think about the spondyloarthropathies. That's a hard word to say. And infectious causes of disseminated rash. I always think first of in the mononucleosis syndromes, also syphilis, Neisseria, gonorrhea, red bite fever, toxic shock syndromes. With this exposure, you can also think about typhoid and for sure infectious endocarditis. We also talked about the workup of septic arthritis. We should always consider blood cultures. The most common causes are Staph aureus and Streptococcus, so it's important to get these early on, but also mucosal swabs for STDs and elaborate more on the sexual histories. And the most important thing for sure is the joint tap. And another important pearl was that STDs travel together, like many things in medicine do, also tick-borne diseases and vitamin deficiencies. So consider checking those in panels. When you think syphilis, always think HIV, chlamydia, gonorrhea. Yeah, and Neisseria gonorrhea has the capability of evading the immune system through evading the terminal complex of the complement system. And a new teaching point for me was also that the joint aspirates sometimes have a low diagnostic value and only 1/3 will be positive for pathogens. And the last point is that pyuria in the absence of positive culture or bacteriuria, which is called sterile pyuria, points either to a non-infectious inflammation, for example, seen in sarcoid or drug-induced, or culture negative organisms that just don't grow in our cultures, for example, gonorrhea, chlamydia, and most importantly, worldwide for sure, TB. Yeah, thank you so much. It was amazing. I learned a lot. And
I mean, that was superb, comprehensive review of all the learning in this case. I absolutely loved it. Thank you. Thank you, Antonio, for a fantastic case. It was really nice to see you back here. I would love to shout out Maria and ask her to tell us more about what's happening tomorrow at 9 a.m. Pacific, a very special VMR.
Ooh, yeah, I completely forgot. Today's Friday. Tomorrow is Saturday. We have a very special Global Virtual Morning Report. We've invited the neurology residency of the University Teaching Hospital of Lusaka, Zambia. Aaron is also going to be there facilitating, and we hope to learn a little bit more about neurology through a case, but also about how they're doing residency and all the cool projects we have going on in neurology in Zambia. So I'm super excited. I can't wait. I'm getting nervous, but hopefully some of you can make it and we'll have a great time.
Amazing. Thank you, Maria. I really hope to see you all there. I can't wait for it. It should be a treat. And hopefully we'll see many of you there. Have a good Friday.
Bye.